I open this academic ceremony in which Mrs. Amodeo is going to defend her thesis, Outcome Prediction in Newborns with Congenital Diaphragmatic Hernia, from Imaging to Artificial Intelligence. I welcome you and wish you lots of success together with your partner. Of course, welcome to the supervisors, Dr. Villamor and Dr. Cavallaro. And of course, the member of the opposition, whom you will meet later. And of course, welcome to the public here on site and online. But before we start the opposition, I will give you the opportunity to present some data from your thesis.
Thank you. Dear Prorector, members of the promotion committee, family, friends, and online viewers, in the next 15 minutes, I will shortly present my thesis entitled Outcome Prediction in Newborns with Congenital Diaphragmatic Hernia, from Imaging to Artificial Intelligence. Congenital diaphragmatic hernia is a rare congenital malformation characterized by incomplete development of the diaphragm and herniation of the abdominal organs into the thorax, disrupting the physiologic cardiopulmonary development. Therefore, after birth, the three main characteristics of the disease are lung hypoplasia, persistent pulmonary hypertension, and cardiac dysfunction. Despite advances in recent years in prenatal and postnatal management, mortality and morbidity of CDH remain high. And therefore, prenatal assessment is essential to provide a prediction of survival chances of the patients. And survival prediction is largely based on imaging and in particular obstetric ultrasound. And what we basically do is to define if the hernia is isolated or associated with other congenital malformations or genetic anomalies. Then we try to estimate lung dimension and therefore lung hypoplasia by measuring the so-called lung-to-head ratio. And finally, we define if the liver position is up in the thorax or in the abdomen. And according to these parameters, and also to the effect side, we try to stratify patients in different risk categories. But in recent years, fetal magnetic resonance imaging has dramatically increased its role over the obstetric ultrasound due to its technical advantages and anatomical definition. And today, segmentation of the lungs is considered the reference technique to quantify the total fetal lung volume. And in patients with CDH, a reduced total fetal lung volume is associated with increased mortality, clinical severity, the need for extracorporeal support, and morbidity. But also we can quantify liver herniation by calculating the percentage of liver herniation, which is known to be an independent risk factor for mortality and extracorporeal support as well. But there are many other quantitative and qualitative parameters that can be assessed at fetal MRI. For example, the mediastinal shift angle is a measure of how much the heart and the mediastinum are displaced in the opposite direction of the hernia due to the presence of the abdominal organs. And as the mediastinal shift angle increases, mortality and clinical severity are supposed to be increased as well. But then, after birth, things change and many other factors come in. So we have to consider specifically the clinical behavior of each patient. Therefore, serial echocardiograms are generally performed to assess cardiac morphology, cardiac function, and pulmonary hypertension. But also imaging is fundamental because we estimate lung recruitment. And we also have to consider all the clinical variables related to patients' characteristics, lung function, and oxygen delivery. For example, at chest X-ray, we can estimate lung hypoplasia by measuring and contouring the perimeter of the two lungs and calculating the so-called chest radiographic thoracic area. And in patients with CDH, a reduced area is associated with increased mortality and pulmonary hypertension, but also with a decline in respiratory function and increased risk of recurrence. However, despite great advances in prenatal and postnatal characterization of the disease, none of these markers provides the clinician with a completely reliable tool for prognostication, and this is particularly true for pulmonary hypertension. In fact, measuring the size of the lung is only an approximation of lung development. What about vascular development, and what about physiology of the lungs? In addition, we have to consider that all transitional changes at birth and ongoing neonatal intensive care make prognostic prediction of these patients even more challenging. But why is prognostic definition so essential? First of all, for counseling the family, but also for centralization and selection of patients for fetal intervention and delivery planning, but also for appropriate postnatal management, in particular for anticipating the need for extracorporeal support, and in general for a more rational resources allocation. And in the light of these considerations, maybe we have to change our approach to the prognostic definition of these patients, and maybe integrating data from different sources could be a winning strategy to give a more comprehensive view of such a complex disease. And that's where artificial intelligence comes in. Artificial intelligence is the field of computer science dedicated to creating machines and software capable of intelligent behavior, and is based on artificial neural networks. In medicine, an artificial intelligence system aims to support the physician in his practice. And in particular, machine learning is a subset of artificial intelligence that enables a computer system to identify patterns in data and make predictions or decisions without human intervention. Specifically, deep learning is a modern extension of machine learning that uses many layers of nodes, particularly good at processing unstructured data such as images. A typical supervised machine learning pipeline consists in several steps that I will try to explain in simple terms. First of all, we have to identify our classes of interest and perform our multimodal data acquisition. Then, during a training phase, we try to teach the machine to correctly classify objects according to specific features. And once the model has been developed, we test the ability of the machine to correctly classify new objects and make generalizations without human intervention, and also for unknown samples. And for the first time in this field, we investigated the application of machine and deep learning to build predictive algorithms for congenital diaphragmatic hernia. As first application, we used a deep learning-based tool for automatic segmentation of lung and liver. Here, you can find an example. Segmentation basically consists in countering the perimeter of the organ of interest, the lung or the liver, on each MRI slice, and then to obtain a three-dimensional reconstruction of the organ. On the left, in red, you can find an example of classic manual segmentation of the lungs on the top row or the liver in the bottom row. And in green, you find an example of automatic segmentation. And as you can see, we obtained almost a completely correspondence between manual and automatic segmentations, showing that deep learning segmentation is feasible and accurate. Then several features, shape features, were extracted from both manual and automatic segmented regions with high reproducibility. And finally, we developed a machine learning tool for classification of liver herniation as liver up or liver down, obtaining a very good accordance between manual and automatic features, showing that machine learning classification is feasible and reliable too. So now, How can we imagine the future of CDH? I think that artificial intelligence will enable us to perform a multimodal data acquisition during the prenatal phase. Then, automatic segmentation of lungs and liver will be feasible, and we will be able to build a predictive algorithm for specific outcomes, for example, survival or severe pulmonary hypertension, but also for selection of patients for fetal intervention or patients who are going to need extracorporeal support. And of course, after birth, other input data will be added to the algorithm for continuous updating of the algorithm, for example, by data from continuous monitoring or echocardiogram or chest X-rays, and in general, during the whole hospitalization, during the whole clinical and surgical course of the patient. And this will provide us, for example, will allow us, for example, to anticipate critical events or defining the optimal timing for surgery or anticipate morbidities like recurrence. And finally, we hope for European data sharing to optimize knowledge in this field, allow for a more rational resource allocation, and finally improving the overall quality of care. So, in 1997, a computer system named Deep Blue defeated the world chess champion Garry Kasparov for the first time. And symbolically, this win was considered the sign that artificial intelligence was catching up to human intelligence and could defeat one of the humanity's greatest intellectual champions. Perhaps today, we are at the beginning of a similar dramatic change for outcome prediction in newborns with CDH, where the relationship between human capabilities and artificial intelligence will no longer be the same.
Thank you very much, dear candidate, for a nice lecture. And now we can start the opposition. And the first opponent is also the chair of your assessment committee. That's Professor Dompeling. He's professor of pediatric pulmonary diseases in the Maastricht University Medical Center. Professor Dompeling.
Thank you, Pro-Rector. So, Ms. Candidate, so congratulations with your excellent thesis. I was really impressed by your work, and especially with respect to I think it's a very clever idea. It's very innovative. So that's, and also I want to congratulate your team of supervisors with these nice studies. And most of the work is already published, so that's really very good. Of course, I have several questions, and maybe to start with quite an easy one is from chapter 4, in which you use the MRI. So we know that MRI is very sensitive to movement artifacts. So how is it in your study population? Did you see quite a lot of artifacts? How did you correct for that? What was the quality of your MRIs?
Okay. Highly esteemed opponent, thank you for your question. Yes, artifacts, motion artifacts are a problem when dealing with fetal MRI because we have to consider that we manage two patients at the same time. We have the mother, so the motion artifacts from the mother, and then the fetus. So the motion artifacts coming from, for example, respiratory breathing of the fetus or casual general movements of the fetus. So it's very difficult to manage with this. Generally speaking, I could say that the time for acquisition of fetal MRI is very rapid with a very good temporospatial resolution. So, and there are also some compensations made by the software to reduce the artifacts. But it's true that in our work, we decided to select the best images we had. So the radiologists critically revised all the segmentations available, all the images available, and decided to perform the segmentation on the best quality images.
How, in your clinical daily work, how does it work? Do you is there someone present during the procedure, and does he say, well, this is not good? Is there kind of quality control?
Can you repeat, sorry, your question?
Now, when during this, your daily clinical work, when these kind of MRIs are made, is someone looking to the quality of the data? Do you sometimes lengthen the procedure in order to get the right pictures?
This was only a retrospective work, so we had the image qualities available, so it was a critical revision of the images already available, so we couldn't do nothing to improve the quality of the images.
Thank you. Then I would like to proceed with some questions about artificial intelligence. I work with it also at our team in pediatric pulmonology, mostly more on metabolomics, but that's not so much on radiomics, but that does not make a big difference. And I want to go with you to page 91, figure 4, and there you demonstrate quite some nice ROC curves, receiver operating characteristic curves. So page 91 in the figure 4. I was wondering, your predictive model seemed to have quite nice results. And based on how many parameters was your model built? Did you do something about feature restriction? Did you only select the most predictive ones, or how did you handle that?
Okay.
And the background of my question is that we know the support factor machine is quite sensitive to overfitting, and that you have to keep in mind, not to include that much parameters.
Okay, thank you. Yes, figure 4 shows the ROC curves for liver herniation prediction made by support vector machine. For this classification, we used only shape features. First of all, because the grayscale of the images were so different, so we were forced to make a decision and to exclude different types of features. So we decided to use only shape features, and we first divided the features in 4 classes according to, let's say, the level of reproducibility between manual and automatic features. Of course, with the help of the mathematicians, we performed some tests. First, we tried to make this classification by using all the features together. And then we tried to reperform the same test by using only the most excellent performing features. But
so about 5 or 6, or how many?
It was almost the 45% of the features calculated, so almost more or less 50 features.
50, okay.
And but we saw that by selecting features, results were worse. So it was better to take all the features together, and this was indirectly interpreted as a demonstration, not a demonstration, but as a sign that the features were very accurate, because altogether performed better than when we use selection.
Did you get the same results when you tried, for instance, another technique like random forest, which is very more robust, or neurological networks? Did you have comparable? I don't know whether you looked at that, but
no, we didn't perform the random forest, no, and no, we didn't perform it.
What do you expect when you should apply this model to an independent data set? Do you think that the sensitivity, specificity would drop dramatically, or only a little bit? Of course, you did this kind of leave one out method, which is also a kind of validation step. But when the ultimate proof of the pudding is an independent data set, what is your expectation? Is it's a very good model, or is there still room for improvement? Or?
We are quite positive. We are quite optimistic about that, and we hope to increase the data set, of course, by including new patients, and also by collaborations with other institutions, because, of course, the most important limitation of the study was the limited number of patients included, because congenital diaphragmatic hernia is a rare disease. But despite this, we had a very balanced population between liver up and liver down. So this was an advantage for us because we didn't. And this is for answering to the previous question about the overfitting. So we have quite balanced population. So the overfitting was quite low. We could separate well the two populations. But yes, we are quite optimistic about that.
Yeah, the time is already gone. I would like to speculate with you about future studies, but maybe at the end or during the afterwards. Thank you, and I give the word back to the prorector. Thank you.
Thank you, Professor Dumpeling, for your position. Now we come to the following opponent, who's also a member of the assessment committee. That's Professor Cocolludo. He's Professor of Pharmacology in the Universidad Complutense de Madrid, and that is in Spain. And thank you, Professor Cocolludo, for coming all the way from Spain, albeit online. The University of Maastricht is always glad to have guests from outside. The floor is yours.
Thank you very much, Mr. Chairman. Dear candidate, dear members of the Corona, first of all, I would like to apologize for not being able to be on site. Mrs. Candidate, I would like to congratulate you for your excellent work and for the great presentation. I think you have given a very clear and easy to follow presentation. You have been able to synthesize the most relevant findings of your thesis. I have several issues I would like to discuss with you, and most regarding to pharmacological aspects and especially on how your work may be potentially applied in the pharmacological management of the patients. First, I would like to ask you about, in the introduction section, you addressed the current pharmacological strategies for the treatment of pulmonary hypertension associated with congenital diaphragmatic hernia. So to my knowledge, there's quite great controversy regarding whether the use of inhaled nitric oxide is recommended or not in congenital diaphragmatic hernia. So I would like to know your opinion on that, first of all.
Okay. Highly esteemed opponent, thank you for your question. Yes, there are a lot of controversies about medical treatment of pulmonary hypertension in newborns with congenital diaphragmatic hernia, because there are some specific differences between these patients and other patients with pulmonary hypertension, and particularly for the use and the efficacy of nitric oxide. Nitric oxide has an effect on the pathway of guanylate cyclase and production of cGMP for relaxation of the musculature of the wall thickness, the arterial wall. Sorry, but we are, for example, in the CDH Consensus Consortium, which are the guidelines for treatment for CDH patients. It is advised to use nitric oxide for the treatment of pulmonary hypertension if the patient worsens, if the clinical conditions are very critical. But at the same time, we have evidence also in the consensus by the European Life Support Organization for ECMO patients that nitric oxide could be harmful in some patients. So if you don't have an effect by using nitric oxide, you should discontinue nitric oxide. And there are studies, clinical studies in the literature, for example, the first one, the NINOS trial, who demonstrated a lack of efficacy, a lack of benefit in some cases with nitric oxide. But even worse, in the last data from CDH group, it seems to be harmful in some cases, with a concern about increasing mortality and increasing the need for ECMO. So very controversial. And therefore, it's essential to discontinue the therapy if the patient does not get better. And even when we consider...
Okay. Yeah, no, sorry, go ahead.
Even when we consider different groups of CDH according to echocardio's characteristics, even in the absence of left ventricular dysfunction, sometimes nitric oxide doesn't work, or doesn't work as we supposed to to work.
Okay, so as an extension of this question, what's your opinion on phosphodiesterase 5 inhibitors, which, as you know, are another pharmacological group that also uses the same pathway, okay, somehow. So, what do you think about sildenafil and other PDE5 inhibitors that are very useful in the adult forms of PAH? In both used prenatally or postnatally? What do you think in the context of CDH?
So sildenafil is another pharmacological agent that we can use for pulmonary hypertension. Is an inhibitor of phosphodiesterase 5 and acts on the same pathway by a different modality, let's say, because it blocks the degradation of GMP cyclic. So it should favor vasorelaxation. Sildenafil is commonly used in particular when nitric oxide has not a particular effect or for weaning from nitric oxide. So in the clinical practice is commonly used and it's recommended or suggested by the international guidelines. But its use in the prenatal period of life, it's not validated, it's not possible at this moment, but we have some interesting data coming from preclinical studies when the use of inhibitors of phosphodiesterase 5 are tested to see if we have some effect, and preclinical results are positive in this sense, but there are no today we don't have any official, let's say, translation into clinical practice. And in particular, there are also some initial steps in the clinical setting for the use of sildenafil for clinical purposes in the prenatal, in the fetal era. But the trial regarding sildenafil have been stopped because of some concerns about the prenatal use of sildenafil in other conditions, for example, for fetal growth restriction, where the results were a little bit contrasting, let's say. So we have preclinical data supporting the use of sildenafil and prenatal clinical data posing some doubts about efficacy and doubts about safety in particular.
I have some more questions, but my time, I think it's over. So maybe I can keep it to the end in case we have extra time. Thank you very much, Mrs. Khan.
Thank you very much, Professor Congenital, for your opposition. Now we come to the following opponent, and that he's also a member of the assessment committee. That's Dr. Gavilanes, and he's associate professor in neonatology at the Maastricht University Medical Center. Dr. Gavilanes.
Thank you, Mr. Prorector. Dear PhD candidate, my congratulations for the work you are presenting. The topic you started is extremely relevant for clinical work, and you have had important data and developments. And I'd like to congratulate the promotion team, to Professors Villamor, Mosca, and Cavallaro for this productive international collaboration. Dear candidate, I would like to ask you two questions related to machine learning and big data. And the first one, can you give us examples of their applications in neonatology, of course, for pathologies or conditions other than diaphragmatic hernia?
Esteemed opponent, thank you for your question. In recent years, I would say in the last 10 years, there has been an increasing application of artificial intelligence in neonatology. And first of all, I would like to underline why neonatology or the neonatal field is interesting for artificial intelligence. First of all, because I think it's let's say, a relatively small population in comparison to the whole life of a subject. So we have a very defined period of life. Then the history of the patient starts with the birth. So we have a very precise starting point, which helps with data collection when we are investigating some phenomenon. And then in particular, in the neonatal intensive care unit, we produce a very huge amount of data coming from static evaluation of the patient. I don't know, maybe laboratory tests or clinical conditions in a precise moment, but also continuous monitoring, heart rate, saturation, oxygen saturation, and so on. So we can have also a dynamic view of patient's clinical condition. And this is very interesting for artificial intelligence because we can combine the two observations. When we think to artificial intelligence in neonatology or in medicine, let's say, we have two main fields of interest. We can make classification, for example, of images to correctly classify patients with having an illness or not, having a complication or not. But also we can have an application of artificial intelligence for prognostic algorithm, so a dynamic application of the artificial intelligence. And both are very interesting for the NICU, and that's why we have also other examples of artificial intelligence for the NICU, for example, in sepsis or, for example, for necrotizing enterocolitis, but also for the use of imaging and machine learning, for example, for retinopathy of prematurity, are very interesting examples. Sepsis and enterocolitis, necrotizing enterocolitis, have the characteristics to be, let's say, very, let's say, when the patient develops the symptoms of the disease, could be too late, could be too critically ill. So it's very important to take decisions and to make intervention before the clinical manifestation of symptoms. And for example, for neonatal sepsis and late onset sepsis, the only commercially available system for monitoring this situation is the HERO system that we use, for example, in our NICU, which is a method, let's say, a software giving a score or an estimation of how high is the probability that this patient will have a sepsis in the next few hours, clinically or culture proven. And it is demonstrated in a clinical trial that mortality after HERO implementation dropped of about 20%. So it was a very interesting result. And for necrotizing enterocolitis, we have both preclinical applications, but also clinical initial applications of artificial intelligence for prediction of risk factors, but also to correctly classify patients as having a NEC or not, because also the definition of NEC sometimes is very difficult, and sometimes it's too late when I see radiological signs in the baby. And it's very interesting also because in necrotizing enterocolitis, in the literature, there are some efforts to combine also, let's say, unexpected data. For example, data coming from the study of the microbiome. And there are some examples of how changes in the microbiome is predictive of having the pathology. So there are both interesting applications. And for the images, I could give an example of retinopathy of prematurity, where classification of the images help the clinician in defining if this baby has plus disease or not. And this is very important because plus disease is an indication for treatment. So it's a very important support for the diagnostic process and for standardization of following the patient and the effect of the treatment later.
Well, dear candidate, well, I agree completely with your rationale and suggestions and conclusions. I wonder, Mr. Prorector, do you have time?
No, you have no time left.
Not for the second, not for the third.
Thank you very much.
The word is returned to you.
Thank you very much, Dr. Gavilanes, for your opposition. We come to the following opponent, who's also a member of the assessment committee, and that's Professor Mulder. And he's professor of neonatology in the University Hospital in Antwerp, and that's in Belgium. And thank you coming all the way from Belgium. Professor Mulder.
Thank you, Mr. Prorector. It's better.
Mrs. Candidate, my congratulations also for this very interesting work you did on a very important topic, and also want to congratulate your team of supervisors who have helped you with this. I really enjoyed reading your manuscript, and I enjoyed also your very nice presentation. Thank you for that. I also have some questions, and I would like to focus a little bit on chapter 2, the mediastinal shift angle paper. And there you make associations with the mediastinal shift angle and clinical outcomes. And just a short question. Maybe I didn't read well, but I missed, for me, a very important clinical outcome, and this need for ECMO. And I didn't see that in your listings of clinical outcomes. Why didn't you look at it?
Highly esteemed opponent, thank you for your question. Yes, neonatal ECMO is a very important outcome, but when managing or when analyzing data regarding CDH, numbers are very limited. So we had a very small population of about 40 patients. So it was very difficult to make predictions with very few cases of ECMO. So we had, in the same period of time, we just had at that time like 6 or 8 ECMO cases. So the predictions would have been completely unsolid, let's say.
Yeah, then I completely understand. Yeah. Then you show that patients receiving milrinone, they were associated with a higher MSA than patients not receiving milrinone. What I also could not find in your paper is what criteria you used to start milrinone. So is this a subjective discretion of the neonatologist, or do you have protocols for that? Because in research, it should be very clear when to yes or no. Eh?
Yes, thank you for your consideration. Yes, it's not specified in the paper, but in our NICU, we perform serial echocardiographic assessment of the hemodynamic status of the patient, thanks to the presence of cardiologists and also with skilled neonatologists in echocardia. So we perform the echo every day, and even more than once a day, just to follow the progression of the disease and to monitor the hemodynamic changes of the patient. So when we see that the patient has at the same time a need for vasodilation therapy, for pulmonary vasodilation, but also as a needs as support to the cardiac function, we start milrinone.
Yeah, but on what criteria? Tricuspid regurgitation, or what do you use as criteria to start the milrinone? Or is it just eyeballing on the echo?
No, we calculate, the main parameters we consider are if it's possible to estimate the pulmonary arterial pressure, but it's not always possible, the presence and the direction of the shunts at the level of the ductus arteriosus or at the foramen ovale, the position and the aspect of the interventricular wall, contractility, ejection fraction, so functional, but also morphological parameters.
Yeah, but still it's a sum of subjective I think interpretation of the echo. You don't use concrete a pulmonary pressure or
no, we don't have a specific cutoff.
Suprasystemic pressure or so.
No, we don't have a specific cutoff.
Okay, then I think my last question will be, in the discussion, you discussed that if newborns have a higher MSA, then these would be candidates for preventive management for a better cardiac function. So you are alert on this, and then you would have preventive management of cardiac dysfunction. What kind of preventive management are you thinking of then?
Short answer, please.
Patients with higher MSA, it was our interpretation of our data. We associated the MSA with more the hemodynamic status of the patient due to the displacement of the heart and the structures on the opposite direction. So maybe we can expect a more critical hemodynamic situation, and therefore we should evaluate, thanks to echocardiogram, for example, the patient very early after birth and start an echo-guided therapy, pharmacological therapy, just to, let's say, make intervention very early and targeted, like very tailored on the patient. That was the meaning of our study.
Which you do not in other patients with a higher MSA or lower MSA. Which you do not when the MSA is not so high.
We leave that for the following opponent. Okay. Thank you very much, Professor Mulder. Then we come to the following opponent, who's Dr. González Luis, and she's pediatrician, neonatologist in the Hospital Universitario de Las Palmas de Gran Canaria in Spain. And thank you, Dr. González Luis, for coming all the way from Gran Canaria, albeit online.
Hello, good morning. So, dear candidates, first of all, I would like to really congratulate you on this great work, and of course, to thank the University of Maastricht for giving me the opportunity to take part in this defense. So I will try to be brief in my comments and the few questions. One of the concerns, so the first one, so the analysis obtained by the MRI, which was insisted on determine the probability of pulmonary hypertension. So related to the chapter 3 with the Clanis protocol, you use both machine learning and deep learning approaches to create a system for segmenting the fetal lung in MRI in order to measure lung volumes and predict the pulmonary hypertension as the first outcome. But then in chapter 5 and 6, you use the postnatal radiographic lung area measured on day 1 of life as a tool for predicting long-term respiratory function. So I wonder if it will be possible to see a relationship between your results with the conventional X-ray images at birth of the children who underwent fetal MRI in terms of clinical prognosis. This is my first question.
Thank you. Yes, I think that it could be possible to find a relationship between MRI data and chest X-ray data. And actually, this is a very interesting suggestion because this is analysis that we didn't perform, but since we are talking about the same study population, could be interesting to find a correspondence or a relationship between these two images modalities. But of course, we have to consider limitations of each imaging modality, in the sense that the chest X-ray, it's more sensitive to our intervention. We are talking about an already born patient. It's very influenced by mechanical ventilation and by our intervention and pharmacological support. And it is also more position dependent, because if the patient is rotated, we could underestimate or overestimate the radiographic area. On the other side, we have the magnetic resonance imaging, which is much more accurate in evaluating the dimensions of the lung. First of all, because it could provide a three-dimensional estimation of lung dimensions. And it's not position dependent because it's, let's say, a slice of the fetal body. So we can have a very reliable reconstruction of the organ. So maybe it could be interesting to implement a magnetic resonance imaging also in the postnatal period to make a real comparison of the two situations of the lung before and after birth. That could be very interesting.
Okay, that was exactly my second question related to the MRI immediately after birth, if that could be more helpful than a conventional X-ray in analyzing future complications. So, but I think you already answered that question. So thank you very much.
Thank you very much, Dr. Gonzalez-Lewis, for your opposition. Now we come to the following opponent, and that's Professor van Gemert. He's the professor in pediatric surgery in the Maastricht University Medical Center. And today he has also accepted the role of secretary of this committee, for which I'm very grateful. The floor is yours.
Thank you. Esteemed candidate, also my congratulations to you and your supervisory team for excellent work, actually. You probably imagine that I, as pediatric surgeon, will ask a question about proposition 4. I will read it. Centralization of CDH patients in high-volume referral centers is critical to manage potential complications with an appropriate and personalized follow-up plan. So I would like to discuss with you about this subject. I assume you are a doctor working or going to work in an ECMO center. And of course, these doctors working in ECMO center are always having this opinion. It's the same as the surgeons who doing a minimal invasive approach. I think that's the best thing to do. The other surgeons who don't do this minimal invasive approach will promote open surgery. And actually you don't know who's right because there's no evidence. So everybody's right, actually. So what do you mean with this? Do you mean that all CDH patients should go to should be centralized to a center, or just a proportion of high-risk patients, high risk for ECMO treatment?
Highly esteemed opponent, thank you for your question. Well, I think that centralization of patient is essential, but it's not only my opinion. I mean, also in the CDH guidelines, it's very specified that these patients should be addressed to a tertiary center soon after the first diagnosis for an appropriate multidisciplinary counseling. Even for the counseling should be the patient addressed. This is for several reasons, because diagnosis is very difficult because the estimation of the LHR, the lung-to-head ratio, is very operator dependent. So it's very important to be very precise with this measurement. And also for magnetic resonance imaging, to have the opportunity to perform the resonance imaging in rapid period of time. But also, it is demonstrated that the learning curve of the radiologist, for example, is an important factor in estimation of lung volumetries and segmentation. So there are several variables to be considered. And for this reason, ELSO suggests to refer these patients in a center with a minimum of 6 CDH patients per year. Another important consideration is about survival chances, because in the literature we have data supporting that high volume centers reach higher survival rates. And also for the surgeon, the learning curve and experience plays a fundamental role for the patient. These are several aspects to be considered when centralizing the patient.
Okay, I think for the radiological part, I can agree. But sometimes, for example, in our hospital, we have really good radiologists, and I don't think they do inferior investigation compared to a center, for example, Nijmegen in the Netherlands. But of course, experience does count. Because I'm a surgeon, I will go to the surgery. The surgery of diaphragmatic hernia is actually, like most surgery, not very complicated. At least the principle is not. Just put the content of the bowel back and close the defect. That's it. And I do think we send them to a center, and they are often we get them back within 2 weeks for treating complications, surgical complications. So I don't think for the surgery it's true. The other thing I would just skip, it's in the line of this, to what you are telling about future of imaging. One of the things you have this list, also in their survival of patient, better if you could, estimate pulmonal hypertension would be really, really well. Also the need for ECMO. I don't see how it affects surgery actually. But do you think there will be more indications for ECMO because of the prenatal MRI scanning with machine learning and deep learning?
Okay, I think that our proposal or our aim should be to estimate the risk or the potential risk for extracorporeal life support to correctly address the patient to a tertiary center with an ECMO team. But I don't think this will make the number of ECMO starts higher, because ECMO should be started according to physiological parameters of the baby and the clinical course of the baby. So it's just to be prepared if the patient is critically ill and we have to transfer the patient, because also being outborn is associated with increased mortality. Yeah. If you need ECMO and you don't, you're not born in an ECMO center, your survival chances are lower. So it's very important to for the referral.
Okay. Thanks for your answer. Just one remark: you have to consider also culture. If you're an Italian, I think. If you are in the Netherlands and you have better imaging and a better prognosis for survival, in the Netherlands you will have more abortion, more termination of pregnancies, less ECMO.
Okay, thank you for this final remark, and thank you for your opposition, Professor van Gemert. Then we come to the following opponent, that's Dr. Hutten, and he's a neonatologist in the University Medical Center in Maastricht. Dr. Hutten.
Thank you, Mr. Prorector. Mrs. Candidate, first of all, I would also like to take the opportunity to congratulate you with your thesis, which in my opinion impressively integrates both clinical relevance and very sophisticated research tools. And my congratulations also go to your supervisors and to your research team as a whole, because as we know, research is teamwork, so is work in neonatology. And as a neonatologist, I'm especially interested in the outcome prediction. And you have elaborated on pulmonary hypertension already. And I would like to shift the focus to the pulmonary outcome of the children, so pulmonary function and chronic lung disease. From your research, what do you think are the most promising MRI parameters which can predict pulmonary outcomes of your patients?
Esteemed opponent, thank you for your question. Magnetic resonance imaging for sure plays a key role in evaluating lung development and lung hypoplasia. And what we hope for the next applications of artificial intelligence is to start with not only with shape features of the lungs, but also considering not only agnostic but also semantic features of the lung. Let's say patterns in the grayscale of the organ that could potentially suggest qualitative characteristics of the lung that could be in some way related to specific outcomes, for example, lung function and chronic lung disease. But also, I think that it's very important to start performing MRI also postnatally when the baby is clinically stable, to make a comparison between prenatal situation and postnatal situation and have a reference point for the following outcomes of the patient, because we know that congenital diaphragmatic hernia is a disease that covers the whole lifespan of the patient. So it's a chronic condition in some way. So we hope to find some interesting suggestions from grayscale and patterns of the lung in the prenatal period and long-term outcomes in pulmonary function.
Yeah. I fully agree that the structural possibilities of MRI are not the whole thing, but that you also have the qualitative part of the MRI. And I'm glad you're going to this direction, because, for example, from BPD research, we know that diffusion weight imaging, when you go to an experimental model, the apparent diffusion coefficient is very nicely relating to histology. So I was wondering, there are a lot of also preclinical experimental animal models of congenital diaphragmatic hernia. So would the possibility of correlating histology, imaging, and, for example, biomarkers be something which could feed your artificial intelligence to learn perhaps more or perhaps faster than only clinical imaging?
Yes, of course. I think it could be a very interesting development of the research, combining preclinical data, histological data, and the correspondence with MRI findings, and particularly the grayscale and the gray patterns of the lung. Could be a very important correlation to investigate. And I think that artificial intelligence in general has the potential to keep all these data together, to combine all these elements that are looking at the same problem, let's say, looking at the same organ from different point of views, but generally speaking, we are talking about lung development, and so there are different...
You may finish your answer if you want.
Yes, yeah. just to say that we are looking at the lung from different point of views, and maybe with human capabilities is not able to find the fil rouge of all these elements, but maybe artificial intelligence will be.
Thank you very much for the answer, and give the word back to the prorector.
Thank you, Dr. Hutton, for your opposition. Ms. Amodeo, the time appointed for the defense of your thesis has passed, and this degree committee will now withdraw to discuss the quality of your thesis and of your defense. And I ask you and your company to await the results of our deliberations and our return in this room. I suspend the meeting.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. your time. Cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side, no place like home. If it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Get the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side, no place like home. If it's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side, no place like home. If it's questions that you've got, go the extra mile and die. What's on the line? I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile.
I reopen this academic ceremony. Mrs. Amodeo, the degree committee here present has assessed the quality of your thesis and the way you have defended it. And in view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Villamor is authorized to confer upon you this academic distinction in accordance with Dutch university custom. And I invite your supervisor to now take the floor.
All right, please.
Sorry. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
Then, by the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Ilaria Amodeo, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee and affixed with the official seal of the university.
Well, this is my time. Ilaria, can I name with your name because you are my friend? Ilaria is a remarkable academic who stands out for her dedication and skill. I met her when she was 21 years old. Since then, I have seen a spark of curiosity in her eyes that only great researchers have. Inspired by this drive, I suggested that she travel 1,500 kilometers from Milan to a basic research laboratory in Palermo, in Sicily, to study intestinal motility and the role of dopamine receptors in mouse model. She agreed without hesitation. After graduation in medicine and surgery, she began to specialize. Her research fellowship led to the publication of numerous articles on congenital diaphragmatic hernia. She has studied the outcome of patients with congenital diaphragmatic hernia and has significantly contributed to our understanding of this condition. Ilaria's academic career has been marked by her unconditional dedication to research and her thirst for knowledge. She has undertaken projects ranging from the study of fetal magnetic resonance imaging to innovative artificial intelligence to predict early mortality, pulmonary hypertension, and ECMO in patients with CDH. Her work, published in top-tier journals, reflects a depth of analysis and originality of thought rarely seen. Ilaria's passion for research is contagious, providing energy and inspiration to her colleagues and mentors, me. Her enthusiasm and remarkable work ethic make her a shining example to those around her, demonstrating that with determination and commitment, obstacles can be overcome and goals achieved. Ilaria's integrity, empathy, and collaborative skills have fostered a supportive work environment where ideas and innovation can flourish. She is talented researcher and natural leader, able to lead by example and bring out the best in others. Now, after many years, you are old, we are working together. I am proud to see her grow in confidence and consider her a great researcher and clinician. Ilaria's work has had a positive impact on her group and will undoubtedly contribute to the understanding of the disease. As she continues her work, there is no doubt that she will achieve further success and personal satisfaction. In conclusion, Ilaria is an exceptional graduate student, a source of inspiration, and a model of academic and personal excellence. Thank you, Ilaria.
Thank you.
Thank you, Dr. Cavallaro, for a beautiful laudation. Dear Dr. Amodeo, also on behalf of the Maastricht University, I would like to congratulate you with the degree you have acquired. I've seen a beautiful thesis and a great defense. Thank you for that, and congratulations also, of course, for your supervisors, Dr. Villamor and Dr. Cavallaro, and of course, congratulations for family, friends, and colleagues. And I hope you have the opportunity to celebrate this important scientific day, perhaps one of the most important scientific days in your life. And I hope you have a great career, of course, and always check the balance. You know, that's these days very important. I would like to thank the members of the opposition for their presence and their work, and of course the technical support team for making this hybrid session possible, and the PEDEL. Having said that, we are going to end this meeting. I'm going to just tell you what we're going to do now. We are going to take a picture here, so I hope the photographer can stay. We take a picture with our two online guests, and then we go to the stairs where we make another picture, and then we go to the reception room, and that's where we can congratulate the candidate. Having said that, I close this meeting.
All right, please.
Stopped.